Okay, well, I think for the purposes of time, we should restart. So I'd like to invite Sandipan Dhar to the podium. And it's my pleasure to introduce him as the Professor and Head of the Department of the Pediatric Dermatology Unit at the Institute of Child Health in Kolkata, India. He's been a long-standing IEC counsellor and is a key member of the IEC Education Committee. He's been really fundamental to establishing pediatric dermatology as a subspecialty in India, and he's also got an interest in cutaneous drug reactions. And in fact, earlier this year, he helped to found the Society for Eczema Studies, the first organization of its kind in Southeast Asia, and he currently serves as the president of the organization. And as you'll see from his biography, which is published in the pamphlet, he's published widely and given a number of invited keynote lectures. So today, again, we're going to have a focus on pediatric dermatology here, discussing Filaggrin gene mutations in the Indian subcontinent, and again, continuing, I suspect, the theme of skin of color. So thank you very much.
Thank you very much, Professor Nick Reynolds, for your extremely kind introduction. Thank you, Professor Emma Gutman, for chairing the session. Esteemed and distinguished colleagues and friends, I bring warm greetings from India for all of you. Well, at the very outset, I would like to sincerely thank IEC for giving me this opportunity to present the Indian scenario atopic dermatitis. I am sure that most of you are probably not much conversant with that, what has been happening on the front of atopic dermatitis in India and subcontinent. So this is a unique opportunity, and this is exactly very important quality of International Eczema Council, which embraces the entire world. This is my conflict of interest, though I have been a key opinion leader and advisors to many multinational as well as national companies. I don't have any conflict of interest here as far as this presentation is concerned. Now I shall talk a bit on Filaggrin gene mutation, which we did in Indian pediatric atopic dermatitis population. And then I shall switch over to different types of presentations of atopic dermatitis seen in our skin. Subsequently, I shall discuss about something more. The first question will come, the Filaggrin gene mutation, though started way back in 2006 or maybe 1 or 2 years earlier. Even you will see that even last year also there is a publication on Filaggrin gene mutation. That means this is something which is ongoing. Professor Emma Gutman has shown involucrin, loricrin, and many other genes which are coming up. But still, Filaggrin gene mutation has got its own importance. And second reason is, India has the largest pediatric population in the world and largest atopic dermatitis population in the world, though the incidence of atopic dermatitis is around 7%. But considering the population of pediatric population below 14 years of age, the large number of pediatric atopic dermatitis we get to see. And they come from different ethnicity. I'm sure that many of you will be surprised or rather shocked to know that more than 2,000 ethnic populations' home is India. More than 4,800 religious populations is, the hub of India. So there is wide diversity. Why I am saying all these things? Because we have been discussing so long the heterogeneity of atopic dermatitis and phenotypic genotypic variations. And one single molecule will not be effective for all types of atopic dermatitis. Blanket treatment, whatever it may come, it may be dupilumab, it may be nemolizumab, one single molecule will never be effective for all kinds of atopic dermatitis because of tremendous heterogeneity in the different populations of atopic dermatitis. So we carried out this study because it was not carried out earlier, keeping in mind that FLG varies from 14 to 56% by and large in the published studies, and FLG null variants are distinct and in each population. There is no Indian studies when we carried out it, in our population. And basic idea was to see the filaggrin gene polymorphism in Indian children with an attempt to do a phenotypic-genotypic correlation in various forms of atopic dermatitis. And the methodology was basically, it was a prospective observational multicentric study of 75 Indian children. Sample size is small because the cost of this investigation is very high, this was supported by Indian Society of Pediatric Dermatology, and we had limited fund. It was a study carried out over 2 years period, and the diagnosis was made as per Hanifin and Brackus criteria. Something which is more important, that many of these studies that actually they have addressed the particular, exome of the entire filaggrin. There are 3 exomes. The exome 3 is the biggest exon. So we did the entire filaggrin genes next generation sequencing technology. So this is the flow chart of our study, participants. I'm not going into detail. You can read it on your own so that I can save some time for subsequent panel discussion. This is the clinical characteristic of 75 patients. And as you can see that age-wise, there was not much, difference. So also the severity-wise also. So most of the studies highlight that if there is filaggrin deficient mutant or different filaggrin mutations, so severity of atopic dermatitis is going to be high. In our small population, in small sample size, we didn't find that. That was something very interesting. There are something more which we were in for surprise actually. I'm going to share with you that. Total number of children with FLG null variants were 26. Prevalence of loss of function mutation or LOF mutation was 34.7%. Total number of FLG LOF variants were 20. 16, that means 80% variants were unique or novel, which has not been described in European studies and in other Asian studies. Mainly the other Asian studies been carried out mostly in China, Japan, Singapore, Korea, and Malaysia. So this is the filaggrin LOF variants, busy slide. We found only with correlation with 2 variants. One is variable factors. One is the age, and second one was the IgE level. There are 7 variants which were detected in more than one individual. Total number of children or more than one variant were 13. 11 patients, that is 42.3%, had 2 null variants and 2 had 3 null variants. However, there was no difference in genotypic, phenotypic associations, neither the severity in children who have 2 null variants versus those who have got 3 null variants. So this was mostly an academic exercise, you can say. So to conclude from this study, that this study documented high prevalence of FLG variants. The FLG variants identified were both unique and novel to this population, not reported in any database, particularly in Indian scenario. Because we have Asian and European descents in our country, presence of one or more FLG mutation in an individual did not correlate with the severity of AD, which I just now mentioned to you. There was significant association of FLG variants with early age of onset and elevated serum IgE levels. Here I must say that this study is now ongoing through Society for Eczema Studies, about which I shall be talking in a short while from now. And we are planning to do in large number of patients. So we have arranged funds for that. And the shortcomings of our study, let me accept that these are the limitations of our study, is a small sample size, and because of that, either there can be fortuitous positive result or false negative results. We are fully aware of that. So I hereby acknowledge all those who participated in this study. Dr. Shahana Srinivas from Bangalore was the principal investigator. There are many actually basic scientists. There are many geneticists involved in it. Some of them are dermatologists. It was a team effort actually. The same team will work, probably with addition of few more, for a large number of patients to study. Now, the next part is that I am going to share with you the kind of clinical presentations of atopic dermatitis we see in India and subcontinent. There will be some amount of overlap with Professor Valeria, what she has shown, because I shall also be talking about the skin of color, but I shall take it from a different angle. For this reason, I am showing this conflict of interest slide. Well, more than 2 decades ago, we published this series in pediatric dermatology, a prospective study over 6 years period of 672 children with atopic dermatitis. We found the classical presentations as, Professor Emma mentioned that why in children the face and extensor are more involved. That was a wonderful, description with all these interleukin factors and cytokines involved with it. A very nice explanation of it. But we know that in, since childhood, the lesion starts encroaching over the flexors. Often there is secondary infections by Staphylococcus aureus, which is again, as it is said, most of these studies have shown in Filaggrin deficient patients, herpes simplex infection, Staph aureus infection is more common. However, in our patients, we didn't find. Lichenification is very difficult to treat. Here I must say that in Indian scenario or in the subcontinent, what we say, I always tell my juniors and students that atopic dermatitis, whatever you read in the Western textbook, you do not see that in majority of the patients of atopic dermatitis in Indian scenario. You see classical atopic dermatitis in only 30% of the patients. You see minor forms of atopic dermatitis in 70% of the patients. And severity of atopic dermatitis, moderately severe to severe atopic dermatitis, by and large between 20 to 25% patients. What do I mean by, minor forms of atopic dermatitis? Often the children are brought to us by the parents, doctor, the child cannot walk, having burning sensation, and this is going on for a number of years. With this type of presentation, we know it. It is forefoot eczema or juvenile plantar dermatitis. But where is the difficulty of labeling it as an atopic dermatitis? I think we should label it as atopic dermatitis. All these minor forms I prefer to label them as atopic dermatitis, because the moment you label them as atopic dermatitis, there is a world of change in your approach, including counseling. You tell the parents that, look, this is a very chronic disease and it is not going to disappear within few months or few years. It is likely to recur every year for many more years. So that is my basic intention of highlighting these minor forms of atopic dermatitis, which is more common in India and subcontinent. Eyelid dermatitis, bilateral eyelid dermatitis, often the children are brought with this. The doctors, these are not going. And the pediatricians are saying, don't bother, you just apply a little bit of steroid. They are keeping on applying steroid on the eyelids for months together. So here you have to really chip in and diagnose it as atopic dermatitis. And when we diagnose them, you take the personal and family history of atopy. I do IG also, and most of the patients, all these factors come positive. And we label it as atopic dermatitis with eyelid dermatitis specifically seen. And it is an evolving disease. Atopic dermatitis is an evolving disease. So over a period of time, you have to see whether the child is developing lesions. We have been actually following up these children. And many such children subsequently throw lesions of classical nummular eczema, flexural dermatitis, and all these things. Our rheumatologist colleague often quote in their presentations, this is their very favorite quote, think lupus, then only you will be able to diagnose lupus. I say think atopic dermatitis, then only you will be able to diagnose that atopic dermatitis. Otherwise, you will just label it as eyelid dermatitis and let the patient go, and let the parents, do doctor shopping from one doctor to another. This is another presentation of intra-auricular or retro-auricular dermatitis. Often I have seen my physician colleagues, they are treating it with as intertrigo with antifungal creams. Nothing is happening. So actually these are atopic dermatitis. And you have to tell the parents that, look, this is a minor form of atopic dermatitis. It needs the long-term treatment and follow-up. Initial treatment with topical steroids, oral antibiotics, if there is secondary infection, then moisturization along with antihistamines for a few months. And that actually takes care of the problem of the child. Many such children are brought to me by the parents saying, the doctor, my child complains of tremendous burning of the lips and cannot eat hot food or slightly, India is a place where people prefer spicy food apart from Mexican food. So it is spicy. It is a country of spicy food. So the child cannot take food because unless and until the food is spicy, we don't feel the taste of it actually. So this is atopic cheilitis. Often they present like this. And you have to treat it accordingly. Initially, mild topical steroid like hydrocortisone, followed by, p-macrolimus for a few months, hydrocortisone for 2 weeks, then moisturization along with antihistamines. And that actually takes care of the entire thing. And the parents are very happy, let me tell you. But you have to level them as atopic dermatitis with atopic cheilitis. Often what happens, the child, as a result of tremendous burning, just to give relief to the burning sensation, starts licking her or his own lips. As a result, this type of lip lickers dermatitis happen. Well, posterior thigh dermatitis is fairly common in our population also, both in small children as well as, older children. But the problem is what Professor Valeria highlighted, the hyperpigmentation. It's extremely difficult to treat. Now coming to another very important thing, this I often ask my pediatrician colleagues and dermatologist colleagues, that by and large our concept has been over the number of decades that to develop lichenification, the eczema should be of some standing for 5, 6, 7, 8 years. Here there is a 5-month-old baby which was brought to me with excruciating pruritus over the vulva. The parents were totally tormented, devastated with the pruritus of this small baby. And this part of the globe I belong to, pinworm infestation is a very common thing for vulval pruritus. Anthelminthic was given, few courses, nothing happened. And look at the lichenification. Just 2 months of history of pruritus. And the degree of pruritus led to lichenification. So this challenges the very concept that atopic dermatitis or eczema has to be a few years of standing to develop lichenification. So it once again highlights that different types of skin, its heterogeneity and different type of response in the same kind of stimulus. So you cannot simply put them in a blanket statement or a big box that yes, these are the features. There is wide variability of presentations of atopic dermatitis as well as treatment response also. Counterpart of atopic vulvovaginitis in small children, this is very common in my practice. I often see such atopic penoscrotal dermatitis, which takes long time to go. And most important thing you can do is proper counseling of the parents because they are very, very tense. Well, all of us know that approximately 30% of infantile seborrheic dermatitis turn over to atopic dermatitis. For a long time we know this. But here there is a 1-year-old boy, as you can see, with who started with infantile seborrheic dermatitis. And look at this excoriation, bleeding, erythema. We were talking about erythema in black skin of color, but there are 3 types of skin, Fitzpatrick skin. 3 types of skin, type 3, type 4, type 5, all exist in India. If you go to the northern India, like Kashmir and Himachal and northeast part, you will see white color skin, type 3 skin. So here you can see this erythema, you can see the excoriation, you can see the cracked lips. So it is a transitional phase of atopic seborrheic dermatitis. Secondary infection by staph aureus is fairly common in Indian scenario. And we have published on that extensively, even from International Eczema Council also we have published in 2019. Another important aspect I shall come, which probably is not known to most of you, that this is the map of India. As you can see, those areas which are in red are extremely hot areas. Those which are in yellow are moderately hot. Only the green areas are colder areas. Hot areas means where almost 7 to 8 months, starting from March to end of September, this month, the temperature soars up to 30 to 45 degree centigrade and relative humidity 80 to 95%. As a result, there is development of miliaria, and the miliaria leads to eczematization, or when it subsides with brownish, fine brownish scales. So this is miliaria. And looking at the face, I am sure that anybody who is not very conversant with malarial dermatitis would like to diagnose an atopic dermatitis in this child. And another interesting twist in the tale, let me tell you, friends, now this study is ongoing in our Institute of Child Health, that many such malarial dermatitis we have seen later on, they have been gradually converted to atopic dermatitis. So whether it is a coincidental or it is a precipitating factor of atopic dermatitis, only a large cohort will be able to find that out. And there is already an established concept in a well-known journal about the subclinical miliaria is the factor responsible for producing atopic dermatitis. Post-inflammatory hypo and hyperpigmentation, both are very distressing to treat, even around the lips also, for lip liquors dermatitis, posterior thigh dermatitis, I have shown you. This is very difficult. With any amount of treatment, they don't simply go. Another thing is lichenification. You see the kind of lichenification. Professor Valeria has shown you some lichenification in, type 4, type 5 skin. These are, even with the best possible treatment, they simply do not go. I must tell you here, one important observation we have made, though very small studies, only 25 patients study, because, dupilumab, there is, unlike many countries, it is not covered by insurance. Patients have to buy it from their pocket, and it is exorbitantly costly, all of us know. First study on dupilumab we published just, last year. What we found that dupilumab reduced hyperpigmentation in children who had severe hyperpigmentation to a great extent. So only in the days to come we will come to know how much effective it is in reducing this hyperpigmentation, because so far we have not found a single drug, systemic therapy. This degree of lichenification doesn't go with any treatment. This type of lichenification. Now we have, earlier assessed the severity of atopic dermatitis in Indian children, but in northern Indian children, we found the severity is much less. We published that in British Journal of Dermatology, and it was more or less perceived that severity of atopic dermatitis was less in India, and this particular article was quoted in Rook's textbook of dermatology for 2 consecutive editions. But subsequently, there has been a paradigm shift over the last 2 decades. We have been seeing quite a number of severe cases, 20 to 25% cases. Earlier, we never used to see more than 5% cases of severe atopic dermatitis. So here lies the importance of systemic therapy, immunosuppressive therapy. Even 5 to 6% of our patients do not respond to cyclosporine or methotrexate. They need dupilumab therapy, or maybe JAK inhibitors in the days to come. So all these severity scoring and other things we will collect data, we'll maintain registry in a very comprehensive way, and that's why, friends, the Society for Eczema Studies have started on 28th March of this year in India. It is just slightly older than 5 months. It is the first society of its kind, though there are many societies across the globe. The first society which will extensively and very focused way study atopic dermatitis and other types of eczema, but by and large atopic dermatitis. It will do research, collect data, because what I have told you earlier, here I am showing you in figure, the incidence of atopic dermatitis today is approximately 7.2%. Now India's population is 140 crore, of which 26.6% is below 14 years of age. So that comes to 37.2 crore pediatric population, the largest in the world, with an incidence of 7.2% in atopic dermatitis. The atopic dermatitis pediatric population comes to 5.16 crore, which is 5 times more than United States, because it is slightly less than 1 crore. So, but we don't have enough data, because nobody has ever taken the initiative to collect data in a very comprehensive manner. And hence the Society for Eczema Studies has been created to promote academic activities, to promote research, to collect data, to maintain registry in the field, and to do conferences, webinars. There are various committees, like academic committee. I am very happy that Professor Dipankar Dey is here from India. He is from PGI Chandigarh. So, Dipankar, could you please stand? He is our convener of academic committee. Thank you, Dipankar, for being there. So, there are several committees, as you can see, more than 120 top academicians of Indian dermatology. They have joined this society. This is our national advisory board. And this is our international advisory board. I am very happy to share with you that some of the legends in the field have very kindly consented to be on international advisory board. It starts with Professor Amy Peller. I am very thankful to Professor Amy Peller, Professor Emma Goodman, and Professor Nick Reynolds, our 2 chairpersons, and many others. I approached Professor, Robert Vishnuet, but he very clearly said that it will be conflict of interest. I really appreciated his honesty, because he cannot be there on 2 societies. But I am sure that in the days to come, Robert will be on board. And he assured me that, Sandipan, you don't worry, I'll support you from outside. Thank you, Robert. This is the website. And first national conference of SES is going to be held on 17th and 18th of December in Kolkata. That's it. Thank you very much.
Thank you so much for this very nice presentation. Do we have questions from the audience? I have a question. So what clinical trials are available right now in children in India?
Right. A very pertinent question, Professor Emma, as expected from you. Currently, we are undertaking a multicentric epidemiological and clinical data collection on atopic dermatitis in children. It will be from 40 centers across India. And basic structure of it was made by Professor Dipankar Dey and modified by our academic chairperson. And we are expecting that next 2 to 3 years we will have a robust data on atopic dermatitis, and many unknown things which were not earlier noted will come to know. Very comprehensively we are doing it, and with proper statistical evaluation and taking proper help of the other associated specialists like pediatric immunologist, pediatric pulmonologist, so to see the atopic march and all these things. Second, we are doing a study on proteomic studies, which you have mentioned, the wonderful study which you have carried out with TEPSTIP method. We are planning a proteomic studies. We are planning a metabolomic studies also. And we have already started the initial part of extending this Filaggrin gene mutation, because we found very interesting result. And we believe that if we do it in large number of patients, something more interesting may come up.
Any other question? Valeria?
Thank you, Sandipan, for your excellent talk. I have a question. You showed India map showing very hot areas on the west side of the country. How do you deal with the dry skin in those areas? Because you showed a lot of malaria. What is the adhesion of the patients? And do you see any difference in terms of clinical follow-up regarding the dry skin?
This is a wonderful question, Valeria. This is exactly what we face in our country. And I often tell my students and junior colleagues that, see, atopic dermatitis is a double-edged sword for us. That means in northern part of the country, during winter, because of extreme dryness, the place from where Professor Dipankar comes, Chandigarh, where I have studied in the Premier Institute, PGI, or Delhi, or Kashmir, or Himachal. So there, it is freezing cold. Temperature goes below, -5, -6. In Ladakh, it goes below -20, all of you know, Leh Ladakh. So there are areas, pockets in India, where the temperature goes down like anything. During that period also atopic dermatitis aggravates because of the dryness. These are the places where the humidity is also very low. Not like the other places, central part of India, particularly east where from I come, Calcutta, and the western part, Mumbai. So these are the coastal areas where the humidity factor is the main factor during summer. As we know in Hannifin-Reicher's criteria, one of the minor criteria is itch when rashes, right? Sweat leads to itching, right? So these are the situations when there is sweating and the itching. In atopic dermatitis, we see that during the summer. But another thing I would like to share with you, that of late I have been seeing, because there is an economic growth and development of India over the last 5 years or so, now even in the rural or urban, semi-rural areas, many children, they sleep in the air-conditioned room. And I invariably ask the parents, do your child sleep at night in the air-conditioned room? Yes, doctor. Then I tell them that please moisturize the child. Otherwise, during summer months, either the parents don't want or the child doesn't want to apply moisturizer all over the body because they complain it gives the very sticky sensation.
So,
thank you.
Thank you so much. I think we'll limit it to this is the last question because we need to move on. So I'm really excited. So thank you so much.
Thank you. Thank you.